you're also hooking that neuro-bio.
The biggest thing is you're hooking that neuro-bio-tactus up. So when you put the foot on the floor, you're not getting the wrong sensory input to give the wrong motor output. Does that make sense? So you put your foot on the floor and you go, oh, it hurts. All your muscles co-contract. You can't walk across that. You stop the nociception and it doesn't hurt anymore. The bone still takes 6 weeks to heal, but you've got rid of the problem, the joint play, you've got rid of the aberrant pull on the ligaments and no motor response to the nerves. Nerves only respond to a motor signal when they get one. So if there's no sensory coming in to make one, they're at rest in the normal tone, and the joint then should go through its normal free range of motion. Is there anything else we can do to enlighten that? Is any questions with where we? Anyone got any questions? No. Anyone got any difficult cases? They're stuck with something.
Have you had MS where you tell it be localised and left, right, and centre all over your body?
I'll try someone with MS.
Yeah,
because you talk about myelin sheath.
Myelin sheath, yes.
You get a,
I don't know whether you therapy localised, but what you get with MS is that the myelin sheath is breaking down. So instead of the nice coating, sending the right messages to and fro, they're not working properly. And I mean, obviously, it's a degenerative condition that's attacking the myelin sheaths. But what I found, if you work with the cloacals, you can get very, very good results in stabilising MS. Work with the cloacals. Jill had a client many years ago, and he had MS, and she said, "What should I do?" And I said, "Just work his cloacals." So I showed her how to do a cloacal balance. So she balanced all the cloacals. Took about 20 minutes to do it, and he couldn't believe it. It made him buzz for about 6 weeks. It would last about 6 weeks.
The only sad part about it is that I had a lady as well who had MS. And unfortunately, the drugs that they give them are actually the ones that made me collapse. So they give them baclofen, which is a muscle relaxant, and they give them amitriptyline, which relaxes supposedly the smooth muscles in your back. If you mix them together, it gives you severe muscle weakness, and they're giving it to MS patients. So one of the things I actually said to her was, well, I want you to go back to your GP because this, I actually dropped with tachycardia because of them. Is I want you to go back and get this reviewed. And she came back and he said, "Oh no, that's right." And I said, "But you get the side effects are severe. Well, so just be aware of it. But if you do get someone with MS, the cloacals really, really helped. Yeah, but the muscle weakness, if they've got them on that, you're running a battle. Yeah. You really are, because it's a chemical muscle relaxant, and of course you have to muscle.
But also part of the MS syndrome is you're going to have lots of muscular problems because you're losing coordination. So you're probably going to have scratch tests, and basically if the body's either upright or it's not upright. Now if the body's in upright poise, then poise, I call it poise and play. If you're in poise, you can move around in 3-dimensional space. Your body can go forwards, back, all over the place. It can cantilever out because it's like we talked about before with the spoke wheel. It's displacing the weight all the way around the rim of the wheel, the spokes, and the hub. So if your body's in poise all of the time, it's working well. The second it's not in poise, and that's what a sacroiliac lesion does, the second you lose that poise, and the biggest place to lose the proprioceptive poise is the sacroiliac. It's the richest innervated part of the body for sending aberrant signals of distress. So the second we're misaligned, we're in fight or flight, which is basically fall reflex. And so you've got someone that's not working properly, then you can do an awful lot for them by putting them back in poise, making sure they've got no nociception, making sure they've got good nerve glide. And that doesn't cure the MS, it manages the postural part of them moving around in 3-dimensional space. Does that make sense? So there's lots of things you can do that are palliative and maintaining, rather than, you can't cure everything, but you can make things an awful lot better. And any joint that's hurting has nociception. You get rid of the nociception. I've stripped down all sorts of conditions that for someone has been extremely painful, and I've stripped down until the noise reduction and the pain reduction come back right down, because it's nothing to do with the joint motion. You know, it might hurt at rest, or it might hurt with the slightest of movement. That's nociception. And pressure, once you understand that synaptic correction, it changes all of that response, and that's what you're after.
I've got one last one.
Yeah, please, yeah.
I've got a client that's tracking down in the neck, and I think it's coming from the partial and the temporal sort of thing, because I've got him to click it in, and that takes the tension out of down the neck.
Right.
How would I reset that? Because it's stuck, well, obviously, see, trying to move that sort of thing, I'm not really sure. I've tried, obviously, just kind of taking the weight off the neck and trying to move it, but I didn't really unlock it.
Right. So let me see if I understand what you're saying. So it's come from the mastoid, did you say, Chris?
Aye, well, it's tight down there, so I think, see, from the partial or temporal, I got him to put his hand there and like click his heels, and it kind of took all the tension out of there. So I think it's coming from further up the way, but I'm not 100% sure because I've not done any cranial.
Right. The thing is, once it starts to come into the cranial domain, there's some things you can do with the level we've got, but you may need to do something more specific. But what you've got is a fair amount of muscles. You've got your trapezius muscles coming up here. They can cause problems because they attach to the occiput and the mastoid. You've got the sternocleidomastoid muscle, which unfortunately is a very poor. So let's draw a head, draw a nose, draw a lip, chin. So this point here is the coronal plane of the head, and it passes right through.
Hold on. Can't see that. I've zoomed into you.
Right, and it passes through this point, just about where the styloid process is. Now, from the styloid process, you've got the stylomandibular and the stylohyoid ligaments coming off of the styloid process. Now, the styloid process is actually the bottom of the temporal bone. Now, both temporal bones move reciprocally the same as your iliac bones. So the temporal bone here, it goes posterior and medial in its flexion phase, and lateral and anterior in its extension phase. So it's moving like that, and balanced by the hyoid muscles, which the styloid and everything's coming to the hyoid. So even an imbalance of the hyoid could affect the jaw muscles, can affect the temporal bone. The temporal bone in and of itself can get stuck because of the occipital triangle that can be affected, so the upper cervical triangle. So what I would do is I would go to underneath the head, find out the side of tension that I've got. So we'll assume it's this side for the camera. So I've got both my fingers under the nuchal line, and I'm feeling now the upper cervical triangle. And I go, right, this side's the tightest. You also wouldn't be able to do an occipital slide, you know, the stair step.
I know you can't now.
Yeah. So I'm now going to take the fingers of my left hand and move them across, so that now my fingers of the left hand are on the upper cervical triangle. Right. Now, at that point, I can take hold of the ear. Now, the ear, the pinner of the ear is obviously on the temporal bone, but the biggest portion of the temporal bone is interosseous. It's about the length of a finger, like this. Now, inside of that, you've got the vestibular orientating reflex, which is basically the semicircular canals, and they're filled with fluid, and they've got little hairs in there. And as you move your head with your eyes closed or open, that's sending balance information to the hyoid, the eyes, and the hypothalamus. So that's basically giving us spatial awareness. Now, if that's not working properly, then we're going to get neck restrictions, head orientation problems, possibly dizziness, and even you could get symptoms in the shoulder, down the arm. Now, again, what we're going to do is we need to relax the muscles at the back of the neck, and I'm going to take the pinner of the ear, and I'm going to find if there's any direction that I can pull it in that's tense, causes a tension to here. So I'm wanting the tension coupled with the fingers here. So once I find an area that's got tension on it, I'm going to increase that pull, and that again sends stronger messages through, so we're not getting noise interference coming to there. And that can also balance the interosseous tissue and the vestibular orientating reflex to a degree. And that will give you some degree of balance in the mastoids. Then coming down from the mastoids, you've got the posterior dorsal scapular nerve, which comes in between. So this is the brachial plexus. There's a head over there, Paul. Can you pass me that one? You see it? Thanks. So what you've got here is, these are the scalenes. I don't know if you can see this quite well. If I come back
There,
there,
come
that's
there.
good. Yeah, that's good. So what you've got here is, this is the only model I've found that has this on, is these nerves here are the ones that we want to get rid of the interference of. The brachial plexus, as you can see on this model, is lower down. So you come from C5, 6, 7, C4, 5, 6, 7, becomes the brachial plexus coming through the shoulder that way. But here, these get in between the anterior and the medial scalenes. Now again, they're attaching to the transverse processes of C2 to C7. So if they're tight, that can have the ability to pull the neck across. The vestibular orientating reflex has to correct it. All of that results in pulls around the mastoid area. The stylohyoid muscles and stylomandibular and muscles of the tongue can all be part of that affected. Now, because that's a motor nerve to the rhomboids and the levator scapula, we don't get headaches from it, but it causes a lot of aberrant interference. So again, that's why we strip down the scalenes to separate where that gap is, to take the pressure off the dorsal scapular nerve. And again, that can be a big cause of tension around that area. But obviously jaw corrections as well.